Good evening, everyone. Let us begin today's session with Omkara and followed by NMO mantra. Om. 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 NMO mantra. Natvaham kamaye ratyam nasvarkam na punarbhavam kamaye dukkadhaptanam praninamurtinashanam. A warm and heartfelt welcome to all the participants of the NMOAP Med-Katalyst Foundation, the Zero Hour Revision Series. Today is day 6 of our 15-day rapid revision series for the first year MBBS students through focused and high yield revision sessions. The session is the subject is physiology, understanding the functions of the life. The topics are reproduction and endocrine physiology. The subtopics are spermatogenesis stages and regulating factors, menstrual cycle, hormonal ovarian uterine changes, insulin synthesis and action, and diabetes mellitus. It is a privilege to have Dr. Renuka Madam with us today. We sincerely thank you for graciously accepting our invitation. With great respect, I now request Dr. Renuka Madam to kindly take over the session and guide us with your valuable insights, Madam.
Sure, thank you so much. Am I audible?
Yes, ma'am.
First of all, good evening, everybody. Hope you've come back to your hostels, took some snacks, and you're ready with your books. So we will start with our today's session. Is my screen visible? No?
Ma'am, screen share చేసారా ma'am?
Yeah, one second. కనిపిస్తుందా?
Yes, ma'am.
Yes. The first topic, spermatogenesis. We will study the stages and the regulating factors of spermatogenesis. First, see, we will not discuss each and every point. Rather than a complete theory, we will go through. See, if we learn something today, you will be able to reproduce it in the exam paper. Imagine the exam paper in front of you and just go through the points. You see, if I'm telling you, I will be telling you in a particular order, definition or flow chart or something, the factors. So whatever you are learning today, you should be able to reproduce it as it is in the question paper. Okay, I'll make it easy for you. If you have any doubt, you can just ask me. Unmute yourself and you can ask me. Okay, I will start now. Very good. Spermatogenesis. The process of development of male germ cells or the primordial germ cells into spermatozoa is called as spermatogenesis. We all know this. See, in the embryo, the germ cells will be present and they will be descended into the testis. In the testis, what happens? Till the puberty, male germ cells are inactive. Till puberty, male germ cells are inactive because there are no hormones, no FSH, no LH, no hormones. So the germ cells are inactive. Whenever puberty begins, there will be hormonal influence on the testis. Due to the hormonal influence, the male germ cells will be transformed into spermatozoa. This process is called as spermatogenesis. So to begin with, we have learned the definition. Where does this spermatogenesis occurs? It occurs in the seminiferous tubules of the testis. It begins at puberty, as we have learned just now. It occurs under the hormonal influence and it continues throughout the adult life. And in old age, it gradually decreases in the old age. This spermatogenesis is controlled by two types of cells, Sertoli cells and Leydig cells. Many other cells also control it, but the most important cells are Sertoli cells and the Leydig cells. Now I'll be moving to the next slide. Course of spermatogenesis. Germ cells are mostly inactive during childhood, as we already discussed. Puberty activates spermatogenesis. Why puberty activates spermatogenesis? Because of the presence of hormones. What are those hormones? FSH, LH, and testosterone. So, once the puberty is started, due to these hormones, the sperm production continues throughout the life afterwards. So, it takes approximately 74 days in humans for this process, complete spermatogenesis. It occurs in the seminiferous tubules. This we discussed already. And coming to the stages of spermatogenesis, you have to remember this as it is in your brain. First stage, spermatocytogenesis. You can repeat with me also. The first stage is spermatocytogenesis. Here mitosis occurs. And then we have meiosis 1, meiosis 2, spermiogenesis and spermiation. I repeat, spermatocytogenesis, meiosis 1, meiosis 2, spermiogenesis and spermiation. Okay, we will go through it one by one. First, coming to the spermatocytogenesis, which is nothing but the mitosis. What happens? You all know that we have this primordial germ cells. Okay, the primordial germ cells enter into the seminiferous tubules. Okay, what happens? There we call them as spermatogonia. They are diploid. 2N, you all know, diploid cells, spermatogonia. Okay. Spermatogonia here divided by mitosis. What is mitosis? Yes, division of cells mitotically. That means chromosomal number will not change. 2N, 2N, 2N. It is diploid only. Diploid spermatogonia will be produced. It is mitosis. This occurs near the basement membrane, and this process, this mitosis, helps to maintain continuous sperm production, increase in the number of sperms, continuous sperm production. What happens here? Diploid spermatogonia will be produced because of the mitosis. Spermatocytogenesis is production of diploid spermatogonia. Okay. Next, coming to meiosis. Meiosis, you all know. Here what happens? Decrease in the chromosome number. Okay. Primary spermatocyte is formed from diploid spermatogonia. Primary spermatocyte is also diploid only. Here, meiosis 1 happens. Meiosis, what does this meiosis do? It decreases the chromosome number. Haploid is formed, haploid chromosome. What is the number of chromosomes in the secondary spermatocyte? 23. Can you see it here? From the primary spermatocytes, after they undergo meiotic division 1, they form secondary spermatocytes with haploid number of chromosomes. And then there will be meiosis 2. After meiosis 2, spermatids are formed. Spermatids. Haploid chromosomes. N. 23 chromosomes will be present. Okay. This is meiosis 2. Primary spermatocyte to secondary spermatocyte is meiosis 1. Secondary spermatocyte to spermatid is meiosis 2. Okay. Equal S, X and Y bearing sperms are formed. Here, see, if 10 sperms are formed, 5 will be X bearing X chromosome, 5 will be bearing Y chromosome. Okay, equal number of both X and Y chromosomes will be present. Spermatids. So, once the spermatids are formed, the spermatid transforms into the spermatozoa, or which we call as sperms. What are the changes that happen to form a sperm? In the spermatid, firstly, the nucleus condenses and it becomes elongated. Elongated. Can you see it here? It is elongated. Okay, nucleus condenses and becomes elongated. Acrosome is developed over the head. You can see the acrosome. Acrosome is developed over the head. Tail and the middle piece are formed. Okay, all the excess cytoplasm will be removed. So finally, it has got the tail and all. So it is motile. It can swim also. Motile mature sperm is produced. Okay, these are the changes occurred. See, for a spermatid to become a spermatozoa, what are all the things that happen? Without seeing, you should tell without seeing. Firstly, what happens to the nucleus? It is condensed and it is elongated. And then what happens? Tail is produced. Body is produced. Tail in the middle piece. Body is nothing but the middle piece. Middle piece and the tail are produced. And the acrosome is formed. Okay. And then all the excess cytoplasm is removed. And motile mature sperm is produced. Okay. Next, coming to the spermiation. What is spermiation? See, here you can see. These Sertoli cells cover the sperm. See, they protect the sperm. See, they are covering the sperm. Okay, what happens? What is spermiation? Once the sperm is mature, once the spermatid is completely transformed into spermatozoa, what happens? That completely formed spermatozoa is released from the Sertoli cells. That process is called as spermiation, and this from here it enters into the seminiferous tubules, the lumen of the seminiferous tubule. Next, capacitation. What is capacitation? It occurs in the female tract. Okay, once the sperm reaches the female genital tract, what happens? The acrosomal reaction happens and the sperm motility will be increased. This is called the capacitation. I'm not going into the detail. This is just the basic definition. Okay, this is what are the factors controlling the spermatogenesis or spermatocytosis. First, hormonal regulation. What happens? LH, you all know, luteinizing hormone. LH, it acts on Leydig cells. Leydig cells produce testosterone. What is the function of testosterone? It promotes spermiogenesis. It promotes the production of sperms. Okay, and then FSH. FSH acts on the Sertoli cells. You just saw the function of Sertoli cells. Then androgen binding protein. It maintains high testosterone. And then estrogen aids in the fluid absorption. All these hormones ensure normal spermatogenesis. We will just revise. What is the function of LH cells? They act on the Leydig cells. Leydig cells act on the testosterone. Testosterone is very, very important for the spermiogenesis. We all know that. And then what is the function of FSH? It acts on the Sertoli cells. Sertoli cells also help in spermiogenesis. And then estrogen. It is used for the. Its function is to absorb the fluid. And then ABP, androgen binding protein, it maintains high testosterone. So all these hormones together ensure normal spermatogenesis. Next, what are the environmental factors? Optimum temperature for this process to occur is 30 to 35 degrees centigrade. That is lower than the body temperature. Testis remains cooler than the body. We all know that because of the scrotum. Okay, testis remains cooler when compared to the remaining body. High temperature decreases the sperm count. So usually sperm count is more in winter rather than in summer. In summer it is usually less. In winter it is comparatively high. And we also have some more points. Hot baths reduce hot bath. Hot bath reduces spermatogenesis, and tight scrotal support may impair fertility. We all know that. We have read it. Okay, these are all the environmental factors. So we will just quickly, any doubts still here? Can we quickly revise? We will quickly revise. Process of development of male germ cells or the primordial germ cells into the mature sperms or spermatozoa is called as spermatogenesis. Okay, this where does this occur? It occurs in the seminiferous tubules. When does it begin? In the puberty. Why only in puberty? Because of the hormonal influence. What are all the hormones? FSH, LH, and testosterone. Okay, and does it stop? No, it continues throughout the life. But does it declines? Yes, declines. It gradually declines with the age. And any cells control it? Sertoli cells and Leydig cells control. Next, 74 days. I think you remember. What are the stages? Spermatocytogenesis, meiosis 1, meiosis 2, spermiogenesis, spermiation. Okay. What is spermatocytogenesis? It is nothing but the mitosis. Germ cells, the diploid, which are diploid, they just enter the seminiferous tubule, where they are formed into spermatogonia, diploid, 46 in number. They divide mitotically. Mitotic division happens. Mitotic is the chromosome number will be same. They just multiply in number. That is mitosis. So diploid spermatogonia will be formed, and then they will be transformed into primary spermatocytes. Primary spermatocytes are diploid, 2n. Okay, and then this is, what is this? This is mitosis, 2n, initially 2n and finally also 2n. This is mitosis. And from 2n, primary spermatocyte, what happens? Meiosis 1 happens, where the diploid becomes haploid. Secondary spermatocyte is formed, N, chromosome N. Only one single set of chromosome will be present. Secondary spermatocyte is transformed into spermatid. This is meiotic division 2. What is meiotic division 1? primary to secondary. Secondary to spermatid is meiotic division 2. And then spermiogenesis. Spermatid converts into the mature spermatozoa, which is spermiogenesis. We have read what are all the nucleic condenses and elongates, cytoplasm, all the excess cytoplasm goes away, acrosome is developed around the head, the tail and the middle piece is formed. Okay, and motile sperm is produced. Spermiation, the mature sperm will be released into the seminiferous tubule from the Sertoli cell. Capacitation, we already read this. This occurs in the female tract. This increases the motility of the sperm because of the acrosomal reaction. And then factors. What does LH do? LH acts on Leydig cells. Leydig cells produce testosterone. Testosterone is very, very important for the spermatogenesis and spermiogenesis. And FSH acts on Sertoli cells. Androgen, by what is the function of it? It maintains the high testosterone. Estrogen, it is important for fluid absorption. So all this hormones regulate the spermatogenesis. Next, environmental factors. What is the ideal temperature or the optimal temperature? It is 30 to 35 degrees centigrade. Testis in the body, we all know because of the scrotum, and the low temperature is very important for the production of sperm. So in high temperature, usually the sperm count is less. In temperature or in winters it is high. And then tight scrotal support should be avoided to maintain the fertility. Okay, any doubts till here? Shall I continue with the next topic? I'll just see. Any doubts till now? If any doubts, you can just unmute yourself and I'll continue to the next topic. Can you give me a thumbs up so I can know you're listening? I'm unable to know. Can you give me an emoji, please? Somebody please give me some emoji that you're listening. Oh, thank you so much. Thank you so much. Okay, we will continue to the next. Done. We will continue to the next slide. Menstrual cycle. We will see the hormonal, ovarian, and uterine changes of the menstrual cycle. First, to begin with, the cyclical changes occurring in the female reproductive system. We know this. Why is this menstrual cycle happening? To prepare the female reproductive system for fertilization and implantation, to prepare the uterus for the fertilization and implantation. Okay, what is the external manifestation or the final outcome is the menstruation. Okay, first menstruation is called as menarche. First menstruation is called as menarche when it occurs around 12 to 14 years. It occurs around the age 12 to 14 years. What is the average cycle duration? It is 28 days. Okay, next, normal cycle is around 21 to 35 days. Normal menstrual cycle, it is 21 to 35 days. Day 1 is the first day of the bleeding, is the day 1. We call it as the day 1. We have read it. Average duration is 28 days. And usually this menses, this becomes irregular when around after 45, when the woman is about to get into the menopause stage, the periods will be irregular, and it stops during the pregnancy and lactation. Menstrual cycle temporarily stops in case of in pregnancy, and the mother is in the child, this menstrual cycle is stopped for a brief period of 6 months, maybe, till the mother is feeding the any regularity. Apart from this, during pregnancy, during lactation, okay, no men, and the menopause there is irregular menses. Apart from this, if there is any irregularity, that suggests some pathology. Okay, then what are all the, this is the important, this is the very, very, very important part. Okay, this you will have to write in your exam. Phases of menstrual cycle. We have 2 phases, follicular phase and the luteal phase. Follicular phase from day 1 to 14. Luteal phase from day 15 to day 28. First come follicular phase. Here we have menstrual phase and the proliferative phase. Menstrual phase, what is the day 1 phase? Day 1, what is day 1? It is the first day of bleeding, we have already read. So that is the menstrual phase. And then proliferative phase, endometrium starts to proliferate and it is preparing for the next cycle. So that is the proliferative phase. This occurs in the follicular phase. And then ovulation occurs at the end of the follicular phase. That is at the around day 14, ovulation occurs. And coming to the luteal phase is also called a secretory phase. Okay, luteal phase remains constant. That is, it is for once the ovum is released, ovulation occurs. Exactly after 14 days, bleeding appears. So luteal phase is always constant. It is 14 days only. Next, coming to the first phase, concentrate. I will make it very, very easy for you. Okay, what are all the changes that occurring in the ovum? What are all the changes occurring in the ovary during the follicular phase? First of all, dominant follicle is selected. This follicle gradually matures. It becomes big and big and big. Granulosa and theca cells, they proliferate. Can you see this? They are proliferating. Okay. Estrogen secretion increases. Antrum becomes large and antrum enlarges. Antrum enlarges. And finally, the follicle ruptures and ova is released. Ovulation is occurring. This is the ovarian changes. What happens in the ovum? Firstly, dominant follicle is selected. Follicle gradually matures. Granulosa cells and the theca cells are proliferating. Estrogenous secretion is increased. Antrum is enlarging here. Antrum is enlarging. And finally, follicle is ruptured. And then ovulation is occurring. These are the ovarian changes. Then coming to the uterine changes, you can see in the diagram above. What is happening? First, menstrual shedding is happening, bleeding. Okay, you can see it on the screen, I guess. Okay, bleeding is happening, and then slowly endometrium is starting to proliferate. Endometrium was proliferating. Glands are becoming lengthened. Glands lengthen. Spiral arteries, see here, very less. Spiral arteries increase. Slowly, spiral arteries are increasing. Endometrium is thickening. You can see it here. Here it is very less. Endometrium is less. Here it is endometrium is thickened, and myometrial excitability increases. This happens in the follicular phase. I repeat, menstrual shedding occurs initially. Endometrium is proliferating here. Endometrium proliferates. Glands lengthen. Spiral arteries are increased. Endometrium thickness is increased. Myometrium is nothing but the uterine lining. It is nothing but the uterus, muscle of the uterus. Myometrium excitability increases. Okay, clear? What are the changes that occurs in the cervix and the vagina? In the vagina and the follicular phase, cervical mucus increases. Mucus becomes more alkaline. Spinbarcate appears. I'll tell you this. Sperm passage is facilitated in the follicular phase. Sperm can easily pass because cervix it is more. Sperms can easily pass through the fluid. Okay, vaginal epithelium cornifies. It is like, I will tell you, I'll show you the picture. And then cornification index increases. Okay, these are all the changes occurring in the cervix and vagina. What are the changes? Cervical mucus increases. This much if you write, it is okay. Cervical mucus increases. Mucus becomes alkaline. Because of more cervical mucus, sperms can easily pass cervix. Next. Here it is clear. These are all the happens in the follicular phase. Coming to the luteal phase, the second half of the menstrual cycle. What happens first? After the ovulation, we are entering into the luteal phase. Corpus hemorrhagicum. Corpus hemorrhagicum is formed whenever the ova is not fertilized. Whenever the ovum is not fertilized, what is formed? Corpus hemorrhagicum is formed, and then corpus luteum is formed. Progesterone secretion is increased, and estrogen is also formed. And then finally, if there is what happens? No pregnancy. So corpus albicans is formed, and then menstrual bleeding occurs. Okay, I repeat, whenever there is no fertilized, ova is converted. What is formed? Corpus hemorrhagicum is formed, and from that corpus luteum is formed. Corpus luteum produces progesterone. You all know this. Progesterone secretion is increased. Estrogen secretion is also increased. Finally, albicans is formed. And then what are all the uterine changes? And gland becoming more tortuous. You can see these glands here are very normal. They are very straight, not tortuous. Here they are becoming more tortuous. After in the phase they are more tortuous. You can see this. And glycogen rich secretion is produced. Glycogen rich secretions increases. Spiral arteries becomes more coiled. See, the spiral arteries are small and straight. Here are becoming more and more coiled towards the end of the luteal, more coiled. Okay, endometrium becomes thick. You can see this here. Endometrium becomes very thick and edematous. You can see this it is very edematous. And venous lakes develop. Here no venous lakes. Here you can see venous lakes are developing. Nothing but the veins. Nothing but the veins. You can see venous lakes are formed. Okay, this is about the uterine changes in the luteal phase. Next, cervix and vagina changes in the luteal phase. What happened previously? It was very thin mucus, huge amounts of mucus. More mucus was present. Okay, sperm was going very fast, very easily. But here, cervical mucus becomes very thick. Elasticity decreases. Sperm and sperm can't go through thick fluid. Okay, vaginal epithelium also proliferates. Very thick mucus is produced. Okay, these are the changes in the cervix and vagina in the luteal phase. Once again, we'll just go through what happens in the ovary. No fertilization, so that the corpus hemorrhagicus is formed. Hemorrhagicum is formed, and from that corpus luteum is formed, and from that corpus albicans is formed, and there will be secretion of progesterone and also estrogen in this phase. And then what happens in the uterine? See, without seeing, you should be able to tell without seeing. Endometrium, what happened? It is edematous endometrium is present. Spiral arteries are coiled spiral arteries are present, and tortuous glands are present. Tortuous endometrial glands are present. Venous lakes are present. What are present? Venous lakes are present. Okay, these are all the changes in the uterus that happens in the luteal phase. And coming to the cervix and vagina, thick cervicus mucus is present. So the elasticity decreases, sperm entry is reduced, thick mucus is secreted. This much, if you remember, it is good. What about the hormones? What are all the hormonal changes occurring in the menstrual cycle? So first, coming to the estrogen. Estrogen is produced by the follicle. When is follicle present? When follicle comes in the picture? During the first half. That is the follicular phase. See, from the menstruation, from the menstrual bleeding, estrogen is not present. Whenever the follicle is the full follicle is growing and it finally is reaching the stage of like day 14, it is whenever just before the rupture of the follicle and the ovum comes out, at that point of time estrogen is major peak, just before the ovulation, just before the ova comes out after rupturing the follicle, the estrogen is very high. Once the ovulation is finished, again it falls down. Again the estrogen comes down, and then throughout the luteal phase it is low only. Finally there will be a little minor peak in the luteal phase. Okay, this much if you remember about estrogen, it is enough. Okay, what is the function of estrogen? Estrogen basically stimulates the endometrial proliferation. First, whenever the bleeding is occurring, endometrium is very thin. After that, because of this estrogen only, the endometrium starts to proliferate. Okay, when estrogen is high, just before the ovulation. After the ovulation, estrogen drops down, and even in luteal phase, there will be a small peak in the of estrogen in the luteal phase. Okay. Next, what happens to the progesterone? Progesterone throughout the follicular phase, progesterone is very less. Okay, immediately during the after the ovulation is finished, immediately the progesterone rises. Okay, and then just before bleeding, just after completion of luteal phase, or just before bleeding, progesterone drops down. When is estrogen at peak? During the ovulation. When is progesterone at peak? Immediately after the ovulation. Okay, 2 points. When is estrogen at peak? Just before ovulation it is at peak. After ovulation it falls down. When is progesterone at peak? Just after the ovulation, progesterone goes to peak and then it comes down. Okay, what is the function of the progesterone? It maintains the endometrium, secretory endometrium. It maintains the secretory endometrium. Okay. LH, luteinizing hormone. It is very low in the, see this red one, this red color is the LH. See, it is very low. It is low in the follicular phase. Just before the ovulation, during the ovulation, it is high. LH surge, you can see, which triggers the ovulation. Okay. And once the ovulation is finished, again it is decline. Again, it declines. Okay. And this LH promotes the formation of the corpus luteum. So, and again, once this is finished, again LH is low. Okay. I repeat, LH is low in the follicular phase. Once, just before ovulation, LH surge happens. LH surge, LH surge stimulates ovulation. It triggers the ovulation. Once the ovulation is done, again it drops down, declines. Okay, what is the function of the LH? It promotes the corpus luteum formation. Okay, after ovulation, again it is low. Next, FSH. It raises, see, you can see a small peak of FSH in the follicular phase. It raises early in the follicular phase. It stimulates the follicular growth. And what happens? It raises again during ovulation, but not as LH surge. LH is too much. FSH, it raises a little bit during the ovulation. And after ovulation, again it goes down. And it is low in the luteal phase. Only during the ovulation, it has a peak. Okay. Then what is the function of FSH? It controls or it supports estrogen secretion. Okay. This FSH is controlled by inhibins. Okay. I repeat, small peak of FSH in the follicular phase and then small peak that is comparatively small when compared to LH surge. It is comparatively small peak during the ovulation period. After ovulation, again FSH is also going to come down. Okay. In the rest of the phase, it is low only. Small peak in the follicular phase and during ovulation, one more peak. That's it. It is controlled by inhibins. What is the function? It supports estrogen secretion. Okay. We will just revise quickly, very quickly. Menstrual cycle definition, I don't want to repeat. And 12 to 14 years it starts. It is menarche. Average cycle is 28 days. Duration of menstrual cycle, normal is 21 to 35, which is the average is 28 days. Day 1 is the first day of bleeding. We have read this all. Okay, phases, 2 phases, follicular phase, luteal phase. Follicular phase, there will be menstrual phase and the proliferative phase. Luteal phase is also called as the secretory phase. What is the number of days? 14 days, which is constant. Luteal phase is constant, 14 days. What happens? Okay, we will not see, or we will just look at one picture and finish everything. What happens in the follicular phase? The dominant follicle is selected. It matures. It gradually increases in size. Granulosa cells and the theca cells proliferate, and finally follicle will be matured. Finally the follicle ruptures and the ovum comes out. This is ovulation happens. These are the ovarian changes. What happens in the uterus? See here, there is thin endometrium. Endometrium starts to proliferate. Endometrial glands also starts to grow. Here, spiral arteries are formed. Okay. Endometrium proliferates. Next, what happens in the cervix and vagina? Cervical mucus is very it is very thin. More mucus is produced. Because of that, sperm can easily enter. Okay, this happens in the cervix and vagina. When coming to the luteal phase, what happens? Oh, if at all the ovum is not fertilized, corpus hemorrhagicum is formed, and then corpus luteum is formed. It produces progesterone. Progesterone secretion and estrogen secretion will be present. Whenever the fertilization is not there, no pregnancy, there will be production of corpus albicans. And then we will see uterine changes. What happens? Here, glands are very normal, not tortuous. Once luteal phases begin, the glands are becoming tortuous, and spiral artery is becoming more spiral. Spiral artery is coiling of spinal artery is present, and we can see the venous lake, glycogen-rich fluid is present. Okay, venous lakes. These are all occurring in the luteal phase. And then coming to the cervix and cervix and vagina, what are the changes? What happens to cervix? Thick mucus is produced, very thick mucus. So elasticity is reduced. Sperm cannot pass through the very thick mucus. And vaginal epithelium is also thick. Okay. And then coming to the, we finished till here. Coming to the hormonal changes, we will not see. We will just see one picture. What happens to the estrogen? It is low just before the ovulation. It has a big peak after the ovulation, and again it drops down. What is the function of the estrogen? It maintains or it stimulates the endometrial proliferation. Progesterone throughout the follicular phase, it is low. After the ovulation, progesterone peaks up, and then again it comes back to normal. What is the function of the progesterone? It maintains the secretory endometrium. Who is producing progesterone? Corpus luteum is producing progesterone. Next, LH. You can see it here. LH is very low in the follicular phase. Just before ovulation, it rises. Whenever the LH surge happens, ovulation is triggered and ovulation happens. After the ovulation, LH again comes down. And in the rest of the phase, it is low only. FSH, it has two peaks. One small peak in the follicular phase and one big peak, but comparatively small peak to the LH. Occurs in the ovulation phase. During ovulation, FSH is high, and after ovulation, again it comes down. Two peaks. What is the function of FSH? It promotes, what is the function of LH? LH promotes corpus luteum formation, whereas FSH, it supports estrogen secretion and it is controlled by inhibins. Okay. Next. I'll just see you. You are listening? Are you all there? Just give me a thumbs up, please. Thank you so much. We will continue. Insulin synthesis, action, and diabetes mellitus basics. Okay. Who is producing insulin? We have beta cells, alpha cells and beta cells in the islets of Langerhans. Where are these islets of Langerhans? Pancreas, I guess you know this. I'm quickly jumping directly into the insulin part. Okay. Insulin is synthesized by the beta cells of the islets of Langerhans. Insulin gene is present on chromosome number 11. This is just basic. You don't have to mention it also. I'm just revising. Okay. Basically, insulin is produced as pre-pro-insulin. Pre-pro-insulin, not mature insulin. It is produced as pre-pro-insulin with 110 amino acids. Okay. It is formed on the rough endoplasmic reticulum. You know that insulin is a peptide hormone. Okay. It contains 4 peptide segments. Okay. We will see. One by one, we will see. Okay. From the pre-pro-insulin, pro-insulin is formed with 86 amino acids. We will see the structure of the pro-insulin. We have A chain, we have B chain, they are connected by the bonds. And here we have C peptide. This is the pro-insulin, disulfide bonds. These are disulfide bonds. They are present. They are holding both the chains, A and B. Okay. C peptide, it is connecting the A chain and the B chain. This is the pro-insulin. Pro-insulin. It is not active. And mature insulin. What happens? The C peptide, this is cleaved. Once the C peptide is cleaved, this becomes mature. This is the mature insulin. Zinc combines with the insulin. Dense zinc and insulin crystals are formed until the secretion. It is stored here. Okay, it is stored. Insulin is stored in the beta cells of islets of Langerhans until the secretion. When is it secreted? Whenever there is food, whenever we take food, whenever the glucose is increased, then insulin is produced. Beta cell secretion. Don't see the diagram. I've just put this to show what is exocytosis. Insulin is released by exocytosis. What is exocytosis? It is a process by which what happens? The insulin granule, this is going to attach to the membrane. From here, the membrane, the pore is formed, and all the insulin present inside is exited from the cell. Okay, this is exocytosis. Okay, through the pore, formation of pore, and all the insulin is coming out. This is exocytosis. What happens? Both C peptide and mature insulin, both are released. Okay, so C peptide reflects endogenous secretion. I will tell you what is this. Our body, our beta cells produce both. First produces proinsulin. From proinsulin, C peptide is removed and the mature insulin is formed. Whenever we test our insulin, What will be present? Both the mature insulin will be present and also C-peptide will be present. But see, what are all the functions of insulin? We will get to know. I will tell what is the use of this C-peptide. I will tell you. Next. Regulation of insulin synthesis. Plasma glucose is the major stimulus. We have read whenever we consume food, whenever the glucose is raised, this insulin secretion will be stimulated. Feeding increases insulin synthesis. Fasting decreases insulin synthesis. In fasting, no glucose is produced. So, insulin is not needed. So, insulin is decreased very less. Glucose increases gene transcription, also increases mRNA translation, results in the increased insulin production. Okay, glucose increases insulin production. Mechanism of action. We will just see the mechanism of action. Insulin binds to the alpha subunit of the insulin receptor. This is the insulin receptor. You can see, okay, to the alpha subunit of the insulin receptors. Who is binding? Insulin is binding. This activates the tyrosine kinase, causing the beta subunit to autophosphorylation. What occurs here? Autophosphorylation occurs. What happens? And then IRS and SHC proteins. There are two types of proteins. IRS and SHC proteins are produced. You don't have to remember so much. So if you just draw this table, or if you just draw a flow chart, it is well and good. Insulin binds to alpha subunit. Okay. And activation of tyrosine kinase happens, causing the beta subunit to autophosphorylation occurs in the beta subunit. IRS and SHC proteins are produced. Okay. Here, gene transcription occurs. Here you can see GLUT4. What is the function of GLUT4? It increases the glucose uptake. Glucose transporter. GLUT is the glucose transporter. What is the function of this? This increases the glucose uptake. Once there is glucose uptake, what happens? All the functions of the insulin. What are all the functions of the insulin? The synthesis of lipids, synthesis of proteins, production of glycogen, and all this function. It utilizes glucose. Through the GLUT transporter, glucose comes inside, and all these things happen. All these things happen inside the cell. Okay. What are the factors that regulate? Carbohydrates, glucose, galactose, mannose, glyceroldehydes, all the amino acids like arginine, lysine, leucine, alanine, keto acids, fatty acids. Hormones like GIP, gastrin, secretin, glucagon, GLP, cholecystokinin, increased vagal activity, acetylcholine, that is nothing but the stress. Acetylcholine, potassium, calcium, theophylline, all these things increase insulin secretion. Okay. Increased vagal activity is parasympathetic. Increased vagal activity, parasympathetic stimulation. Whenever we are meditating or we are very calm, what happens? Insulin is produced. Okay. Factors that decrease insulin secretion. Hypoglycemia when during fasting or during exercise. Somatostatin, leptins, interleukins, beta blockers, hypokalemia, beta cells poisons such as streptozotocin, alloxan, inhibitors of microbial, colchicine. You just have to remember 3 or 4. You just have to mention. If you just mention, you will get good marks. That's it. Just remember 3 or 4 factors. Okay. What are the actions on carbohydrate metabolism? Primary function of insulin is to lower the plasma glucose level or the blood glucose concentration. Primary function of insulin. Insulin reduces glucose levels, plasma glucose concentration, or blood glucose levels. Okay. It is the only hormone that reduces or that decreases the glucose. Okay. The only hormone that reduces the glucose is insulin. Insulin is the only effective anti-diabetogenic hormone. Okay. Insulin increases glucose entry into the cells. It supplies glucose to almost all the tissues of the body except brain. Okay. What are the actions of insulin on fat metabolism? It promotes lipogenesis. It produces fat. It inhibits lipolysis. Breakage of lipids. It stops. It reduces free fatty acids. It increases triglyceride storage. It prevents ketone formation. It conserves the body fat. These are what happens on protein metabolism? It increases amino acid uptake, insulin stimulates protein synthesis. That is why all the athletes, those who participate in races, marathons and all, they consume this insulin so they can grow good muscles. Okay. So what they do, they take insulin injections. Whenever we take insulin injection doesn't have C peptide. They only give mature insulin. We don't have C peptide. That is the difference between the endogenous insulin, which our body produces, and the exogenous insulin, which is the synthetic or the artificial insulin. That is the difference. Okay, what is the function of the insulin? Protein. It stimulates protein synthesis. So this insulin is misused by the athletes. Okay, it reduces protein breakdown. It promotes tissue growth, positive nitrogen balance, anabolic hormone. Insulin is a good hormone. Okay, it maintains it stimulates protein synthesis. Okay, next, what are the overall actions of the insulin? We will just see. It is a hypoglycemic hormone. It reduces the plasma blood glucose or the blood. It reduces the blood glucose concentration. It promotes the energy storage. It gives glucose to all the cells except the brain. It increases glycogen storage, and then it increases fat stores. It increases protein synthesis, and it is essential for the overall normal metabolism of the body. Coming to the clinical part of insulin, which is the diabetes. Okay, diabetes is basically a metabolic disorder. We all know this. It is characterized by the hyperglycemia, sugar antar. They call sugar ochindi antar. Hyperglycemia. What happens? Why does this hyperglycemia occurs? Because of the insulin deficiency. We all know that insulin is the anti-diabetogenic hormone. It reduces the blood sugar. So whenever insulin is not present, blood sugar increases, hyperglycemia occurs. That is where diabetes mellitus comes into the picture. Okay, either due to insulin deficiency or due to insulin resistance, diabetes mellitus occurs. And whenever this insulin is disturbed, there will be carbohydrate metabolism disturbance will be present, and fat and protein metabolism also will be affected, as we have just read. Okay, we will see the classification of diabetes. Type 1 diabetes, autoimmune diabetes. Here insulin will be less, insulin will be deficient. Insulin deficiency will be present in type 1 diabetes, whereas in type 2 diabetes there will be insulin resistance. Insulin resistance will be present in type 2 diabetes. There are other specific types of diabetes also, because of the genetic defects of maybe beta cell function or the insulin action, maybe due to pancreatic diseases such as pancreatitis, pancreatectomy, cystic fibrosis, hemochromatosis, neoplasia. Because of the all these pancreatic diseases, we can have this diabetes. And also due to excessive endogenous production of insulin antagonists such as cortisol. Cortisol is insulin antagonist. In case of Cushing's syndrome, we have lot of cortisol. Okay, in case of acromegaly, pheochromocytoma, they all increase blood sugar levels. So they are called as insulin antagonists. Cortisol increases blood sugar, GH increases, thyroxine, norepinephrine, glucagon, they all increase blood sugar. So they are insulin antagonists. And also drugs such as steroids induce diabetes. Viral infections such as rubella and mumps, congenital rubella and mumps, they also cause diabetes. And genetic syndromes like Turner's, Klinefelter's, and Down syndrome. In these syndromes also we will see early onset diabetes. And the other thing is gestational diabetes. During pregnancy, there is a chance of getting diabetes, which is gestational diabetes. What are the causes of diabetes? One is who produces insulin. First of all, beta cells are producing insulin. Whenever the beta cells are destroyed, the insulin production is reduced. And genetic causes, obesity, physical inactivity, pancreatic diseases, endocrine disorders. Physical inactivity, we saw. Pancreatic diseases, we just saw pancreatitis and all, neoplasia and all. Endocrine disorders also we saw this Cushing syndrome, this growth hormone, acromegaly, etc. We will be seeing diabetes mellitus. What are the clinical features? Polyuria. The person will have the urge to frequently urinate. Frequently he has to go pass the urine. So that is polyuria. Polydipsia, frequent thirst. He has to drink lot of water frequently, very frequently. He has to drink water. Polydipsia, polyphagia. He feels hungry all the time. He has to eat something. Polyphagia. What are the three P's of diabetes mellitus? Polyuria, polydipsia, polyphagia. And then weight loss will be present. All the muscle wasting present. Patient becomes very thin. Why? Insulin is important for protein synthesis. No insulin, no protein, no fat, nothing. So weight loss will be present and fatigue will be present. Recurrent infection. Why recurrent infection? Why recurrent infection? Whenever there is less insulin or insulin deficiency, what happens? Sweet increases in the body. That is more hyperglycemia will be present. Whenever there is hyperglycemia, bacterial growth will be present. So there is recurrent infection. How do we diagnose? How do we diagnose? If the fasting glucose is more than or equal to 126 mg per dl, or if the random glucose, not fasting exactly, random glucose is more than or equal to 200 mg per dl, we can diagnose it as diabetes. And the HbA1c level more than or equal to 3.5%, or oral glucose tolerance test. We do it, oral glucose tolerance test, and if the value is abnormal, we also can. And urine glucose, usually urine doesn't have glucose. Glucose will not be present in the urine. If at all urine glucose is present, we can check for diabetes. And then C-peptide is used to assess beta cell function. Next, complications. What are the complications of diabetic acidosis? First, due to high viscosity, all the tiny blood vessels are gone. There will be damage to the blood capillaries, tiny blood capillaries. There will be retinopathy. Where are the tiny blood vessels present? In the eye. Retinopathy is present. Where are tiny blood vessels? In the kidney. They are present. Nephropathy will be present. Neuropathy, coronary artery disease, and diabetic ketoacidosis. Okay. What are all the complications? Repeat. Retinopathy, nephropathy, neuropathy, coronary artery disease, and diabetic ketoacidosis. And we forgot one more, hyperosmolar state. Hyperosmolar state, or osmolarity increases. What is the management? Medical nutrition therapy. We are getting, see what happens, blood glucose level is so high. So we should eat foods that have very low glycemic index, okay, that don't trigger insulin, okay, that don't need so much insulin, okay. Medical nutrition therapy, regular physical activity, oral hypoglycemic, we have sulfonylureas, we have certain drugs like metformin, etc. We use oral hypoglycemic drugs, okay. Then insulin therapy, we give insulin, and then blood glucose monitoring, constant monitoring. There are some patches, or there is a blood test, okay, blood glucose monitoring, and we have to prevent long-term complications. If you don't take medications properly, what happens? All this retinopathy, nephropathy, neuropathy, all this damage occurs. So we have to prevent these long-term complications, we have to treat the patient, we have to manage the patient, okay, with all this nutrition, oral hypoglycemic drugs, and also physical activity. We have to advise the patient to do physical activity. Done. Thank you so much. We'll just quickly revise. I'll just quickly go. I'll not take so much time. Beta cells, it is produced by pre-proinsulin is produced, proinsulin is produced. It has A chain, B chain, C chain. C chain is gone, C peptide is gone, only A and B present. That is mature. We have disulfide bonds. Zinc is required. Zinc combines with the insulin, okay. It is stored there only until in the beta cells only until the trigger comes, okay. Insulin comes out by the process of exocytosis, okay. And then regulation of who regulates insulin. What is the major stimulus? Glucose. Whenever we eat food, insulin synthesis is triggered. Whenever we are doing fasting, no food, no glucose, so insulin synthesis is decreased, okay. Mechanism of action, insulin comes and binds with the alpha receptor, alpha subunit of the insulin receptor, and then what happens? Beta subunit causing the tyrosine kinase, it activates the tyrosine kinase, causing the beta subunit to, what happens to the beta subunit? It autophosphorylation happens. So two proteins, SHC and IRS proteins, they are phosphorylated. What happens here? We have GLUT4, glucose transporter is present on the membrane. It allows the glucose inside the cell. So all the things. What are all the functions? Protein synthesis, fat synthesis, glucose storage, all the things, all the functions of the insulin is carried out inside the cell. Factors that increase insulin: glucose, galactose, all the carbohydrates, some amino acids like arginine, lysine, leucine, alanine, keto acids, fatty acids, and all these things. And factors that decrease insulin: fasting, exercise, somatostatin, hypokalemia. I'll just go with 4. Leptins. Actions on carbohydrate metabolism. What is the function of insulin? It reduces plasma glucose concentration. It decreases the plasma glucose level. It is the only anti-diabetogenic problem. What is the action on fat metabolism? It promotes fat production, that is lipogenesis. It inhibits lipolysis. It increases triglyceride storage. I'll just read out important. It increases triglyceride storage. It conserves the body fat. What is the function? What is its action on protein metabolism? It produces proteins and it stimulates protein synthesis. It is important for muscle formation. It reduces the protein breakdown. It promotes the tissue growth. Okay, insulin promotes the tissue growth. Next, overall actions of insulin, just I'll read out. It is a hypoglycemic hormone, promotes energy storage, increases fat stores, increases protein synthesis. It is essential for normal metabolism of the body. Diabetes, we have already read it. Hyperglycemia will be present because of insulin deficiency or insulin resistance. We have read the classification. Obesity, physical inactivity, pancreatic diseases, endocrine diseases are the causes. Clinical features, very important. Polyuria, polydipsia, polyphagia will be present, weight loss will be present, fatigue, and recurrent infections will be present. Diagnose: fasting glucose more than 126 mg per dl, random glucose more than 200 mg per dl, HbA1c more than 6.1%, 6.5%, and then oral glucose tolerance test is abnormal, urine glucose positive, and C-peptide. We will assess C-peptide in athletes. Next, complications. What are the complications because of this long-term diabetes? Diabetic ketoacidosis, retinopathy, neuropathy, nephropathy, and hyperosmolar state and coronary artery disease. What is the management? First thing is nutrition. We advise medical nutrition therapy, and then we advise regular physical activity. We give them oral hypoglycemic drugs such as sulfonylureas, which we give them. The most frequently used is metformin, and then we give insulin therapy, and we constantly monitor blood glucose levels, and all these things prevent the long-term complications. Thank you so much. I'll see you. Hope you have understood. Any doubts till here? I'll just stop sharing my screen. Yeah. Am I audible? I'm audible. Any doubts? Any doubts till now?
Yes, ma'am, audible.
Okay. I think we can conclude the session if no doubts.
Yes, ma'am.
Any doubts?
If there are any doubts, please ask in chat box.
Is my voice clear?
Yes, ma'am.
Okay.
ఇంకా డౌట్స్ ఏం లేవనుకుంటా మ్యామ్ వాళ్ళకి.
Okay. Okay.
Okay.
We'll conclude. Thank you.
Okay. Let's end the session with Shanti Mantra. Sarve bhavantu sukhinah, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschid dukkha bhag bhavet. Om Shanti Shanti Shanti. We extend our heartfelt gratitude to Dr. Renuka Madam for an insightful and enriching session. Thank you, Madam, for your valuable time, guidance, and support. We also thank all the participants for your presence and active participation. Upcoming session is tomorrow at the 6 o'clock. Session is taken by Dr. Shivashankar sir, SR at the College of Maulana Azad Medical College, Delhi. Tomorrow's topic is endocrine and acid base and neurophysiology. The subtopics are thyroid hormone and hypothyroidism or hyperthyroidism, acid base balance, neuromuscular transmission and muscle contraction and basis. Thank you, madam. Thank you to all the participants.
Thank you. Thank you.